a very the long process of certification. This is where most of them really hit that wall of finding those residency spots. Can you walk us through the policy landscape of this issue? Why are so many internationally trained professionals taxi drivers? They say if you're in a taxi in Toronto, it's safer than being in anywhere else. And where are the holdups happening? Why aren't we moving forward?
Yeah, thank you for that question. And first of all, thank you to my fellow panelists who I'm excited to learn quite a bit on this issue as well and share learnings. I want to just also highlight Shamira has been doing pivotal transformational work in her current role and before. And so we have a real leader amongst us in terms of this work. And I guess it goes back to that quote that you mentioned, Rania. I think the challenge with internationally trained physicians, but thinking broadly, just people who have credentials outside of Canada who come into our country, we have real challenges around recognizing people's credentials. And this happens across many different sectors. I think about my father. He is an internationally trained electrician. So when he first came to Canada, he had to kind of go through the process of getting retrained and getting his credentials recognized. And now actually, and this was part of my upbringing, he does a lot of work supporting similar folks in the same field through that process. And I think what this shows us is that there is a mismatch happening where we're asking people to come to this country with immense skills and immense contributions that they can make, but we're not actually recognizing it when they land here. And when it comes to physicians in particular, I think it is the barriers around testing fees. It is that entire time. So oftentimes people may decide, I need to feed my family. I need to ensure that I can put food on the table. I need to ensure that I can put a roof over our heads. So this long extended process is perhaps not what I'm going to invest my time in. And I think a lot of people feel a sense of betrayal by the country, where there is this Canadian dream that we purport. But I think the realities of people on the ground is that they are being streamed into precarious labor. I think part of the challenge also is around, one thing I will share is residency spots, and we can debate exactly what the policy vehicle we need to do to really address that issue. But I'll just share one stat, which is in 2019. That there was over 1,700 residents, international medical graduates, but 1,360 were not matched with residency placements. So we have immense demand. Actually, and immense supply, but there's something that happens in between. But I will say this is actually really unfortunate for Canada, because when it comes among the OECD countries, we are a laggard. In Canada, we have only 2.6 doctors per 1,000 residents. Italy, which was the epicenter of this pandemic before the US, and now it's saying a lot in the Latin America, they had double this. So I think it really also speaks to we're missing a key resource. I come from a health equity background, so I look at the ways in which different equity-seeking groups are able to fully realize their health potential. And when we look at the healthcare system, which is just one aspect of health, there's so many, the social determinants of health, we see in many pockets of the country that have high linguistic diversity, many people are not able to access care in a language that they understand. English and French, those are our official languages, but we know people have other mother tongues. Look at the city of Toronto, for example. So I think another potential opportunity, similar to what Shamira said, we have an aging population, but we also have a more linguistically diverse population. So that is something else that I think we can leverage internationally trained medical professionals, health professionals, because they're able to bridge that divide that we are currently struggling with. So that gives you a sense of some of the challenges, but I also see some of the opportunities, because when I think about what Canada should represent, the Canadian dream, we're not there. And I think if we're able to tackle this issue, we can do better.
Amazing. Thank you, Anjum. And yes, I could not agree more, especially on the point building on what Shamira earlier said about the aging population and that diversity, even just from the angle of linguistics, knowing that most people generally, when they age, they do retract back to mother tongue language. And that's where that's just a very, very small perspective of how we can utilize this this population, right? Nicola, I'm going to be moving to you. You're one of the people that I've known your work to be very optimistic, especially in alternative careers and shifts that way. But I'd like to learn more about. I know you're an internationally trained professional. If you can tell us a little bit about your story and if you've had faced those challenges we're talking about, like your lived experience through them. And we'd love to also hear your thoughts on whether it is a changing landscape. How much do you see or have you observed the change within the landscape?
Oh, thank you very much for that question. I think my story is just similar to that of many other internationally educated healthcare professionals, except perhaps for the duration. I came to Canada a little more than 10 years ago, and I was hoping to practice in Canada until I got really faced by the reality or the discrepancy between what is being said before you immigrate to Canada and what is the actual fact when you are in Canada. And the struggles just hit you very fast, as my first job was as a security guard at a grocery store in Alberta in the winter without driving. But at the same time, I have to admit that I was very fortunate because I landed in a province where the policies around practicing or handling restricted medical activities under supervision of a licensed physician were really clear, and you can take advantage of that. So that is one thing. The other thing is that I was really able to take advantage of every opportunities that was presented my way. And one of them was to work as a clinical aide in that program, a pilot program with MediCenters in Calgary. Then I was able to serve as a vice president at the Alberta International Medical Graduates Association, just trying to find ways to improve the lack of systemic support for internationally educated healthcare professionals. The other opportunity that was really I learned from that was to be able to start my own employment agency for foreign trained doctors to open up these opportunities from that pilot program that was initiated by MediCenters. And that was until I moved to Ontario. And this may answer your last question about the changing landscape. It is really a changing landscape, starting with geography, because each province has its own struggles and realities of around access to healthcare for internationally educated professionals. But also a changing landscape because of the fact that there is, it used to be a very straightforward path. You challenge the exam, you pass the exam, and you're in. But now there are way too many internationally educated healthcare professionals that have passed all the exams, have challenged the exams, and are in, they have the qualification, but they cannot get there. And there is a whole other issue around what they're responsible for in terms of that access, but the system itself, how it can support that influx and how it is able to organize itself around that. So I hope I've answered that question.
Thank you, Nikadam. Shamira, I'm going to turn back to you, especially that there's a couple of points that were mentioned here. Andrew brought up the recognition piece. I know that it's probably not recognition as much as it's recognizing the expertise or experience or giving that opportunity. And Nikodem mentioned that the process has been changing, it's been ever evolving, but then also mentioned possibilities of doing like the influx of it or whatnot. So I'd like to, we've heard about the barriers, and we know, it's anywhere around the time it takes to recertify, especially within a profession like physicians. You need to be practicing to really stay on top of it. The fees, the process, and then the barrier that hits the residency piece. But in terms of policy solutions, especially I know that the work you've done in the past, as well as your current work within WES, what could be the policy solutions here? And can you share some of the work that you've done, WES or before WES, that is working on this issue, and how has the policy landscape changed since the start of the pandemic, if at all? Because in a recent podcast that was hosted by the Triac podcast hosted by one of my dear friends, Jenny, she had a lived experience with an internationally trained profession, and she shared her story of trying to get into the field after the pandemic, but it wasn't very clear, and it was actually very wishy-washy that they just wanted them into senior care homes to help with the aging population. So your thoughts on that and the work that you've been doing, and how that can impact policy solutions would be great. You're muted.
There, you could hear me talking.
There we go.
No, I was just going to say that basically, this is a really deep question that is going to take obviously more than 5 minutes. So in terms of basically what has happened in the past, and notwithstanding that people like Dr. Nikodem and others, have been here as recently as 10 years. The reality is that 20 years ago when I started this work, when I was with government, there was nothing. There was just a 300-page report that said occupational bodies or licensing bodies are gatekeepers. And since then, a number of things came into play. Occupational fact sheets that really gave people a really clear pathway of what the steps were. Plain language, how much it's going to cost, what you need to do to prepare. Setting up the bridging programs. Ontario was the first province that set up bridging programs that gave people an opportunity to just bridge from what they already knew to what was the language of the workplace, to what it looked like working in the workplace, to getting ready to write the exams, and then moving into basically the field. Legislation that basically brought about what's called the Fairness Commissioner. We have a Fairness Commissioner that we have in Ontario and 3 other provinces. And the job of the Fairness Commissioner was to hold the licensing bodies accountable, to make sure that whatever processes licensing bodies had in place, fair, transparent, objective, etc. And then on top of that, IMGs, just in terms of background, actually we set up the IMGs that was very specific, X number of spots only for IMGs, and they would have to go through a process. So a lot of progress did happen fairly quickly. And, when I look at it after I came back to the field and came to WES 18 years later, what ended up happening, which is where the issues are, is too many people crowded the scene. Everybody wanted to do bridging programs. All the associations nationally, provincially want to talk about fact sheets. Everybody wants to do websites, and the whole IMG situation got more complex. So I'm going to speak for 2 minutes as a former bureaucrat. There isn't a lot of money on the table from a health perspective. It's health transfers that come from the federal government to the provinces. The provinces make decisions through the legislation, and Dr. Nikodem, you talked about that. It's all about geography. And so what ended up happening is that each province would make a decision as to how those health dollars would be used. And so over time, what ended up happening is those spots that were for internationally trained, the definition of internationally trained changed from you are an immigrant born in another country coming here as a landed immigrant to if you were born in Canada but trained in a school in an international country, you have access to those spots. You can see what happened almost immediately because all of a sudden the spots started going to young kids going to other countries, studying and coming back, and then you're going to the residency spots that cost almost, it used to be $70,000. Who's going to pay? I'm not trying to make it complex. The other thing from a very bureaucratic perspective is when licensing bodies actually put entry to practice requirements in place. They're doing a balancing act. They should. That's what we ask them to do. The entry to practice requirements, the standards have to be there because anybody who gets licensed or registered, whether they're a pharmacist who will basically give us their medication, to an optometrist or to whoever, an engineer building bridges, we need to make sure that they meet the highest standards. So they need to put that in place. But the balance, and read up something called the Lisbon Convention, is do not add additional barriers that are going to just basically put there for the sake of putting it there. So do you really need 5 years of experience? To what end? If somebody has been working for 25 years in their home country and they can demonstrate they could do it. And so that's always the balancing act in terms of making sure that people meet the highest standards in our country, basically with what we need to do, but the unfairness that comes at play. And that's why what you now see is this busyness around the barriers that have been put in place as a way to say, but we're trying to meet standards and they have to meet our standards. And I ask myself the question, to what end? Because the whole area of objectivity, transparency, navigating the process in a way that's fair, somehow we lost sight of that, I believe, in the last 10 years. In the last 10 years, it just got busy. Everybody wants to do bridging programs and everybody wants to talk about these poor internationally trained who are driving cabs. But what have we done about it? Because really, from a practical perspective, we have done nothing about it. And so, the question is, what are we doing now? As soon as we looked at what was happening with the pandemic, we said, here's an opportunity. Let's start raising the conversation again at the national level. Let the senators, Senator Omidvar, who was, the founder of things like the Nurse Care for Nursing Bridging Program, let's talk about it. It's a global issue. We're seen as a leader, and I want to know actually where, because I know that there's some regulatory bodies that do an outstanding job. Medical lab technologists, pharmacists, outstanding. But there are other areas like doctors where I ask myself the question, to what end? The latest area where I know people talk about the fact that, they have the temporary or the provisional license. 12 people have gone through that. 12, that's it. And you have to ask yourself why. So anyway, I'll leave it there. I'm starting to get passionate about it. There's a balancing act. And I think that we need to look at the fairness.
And actually, that's just a quick follow-up that I wanted to ask you. Do we still have a fairness commissioner?
Yes, we do.
We do.
But we can have a separate, yes.
Okay. Yeah, I thought so too. And thanks for taking everyone through that bigger picture, because that's one of the things, especially in PCAN, when we do get internationally trained doctors that join our network, trying to explain this whole complex situation that you beautifully drew a picture. You just summarized it beautifully, and I can just refer them to this video and say, here you go, here's the problem. Anjum, I'm gonna, as much as I'd love to hear Shamira's point of view about it as well, but I would actually like to ask you, knowing I'm sure you've gone through so many of those stories probably in your life, knowing a lot of people going through it, how do you think we can unclog this system? That policy, like where do we need to start?
I think it's exactly what Shamira is saying, like us raising the conversation. I think we've seen over the last 2-3 months the incredible change that we've had responding to this crisis, but also all the complexity around the policy, regulations, legislation. people are figuring out ways to work through the system and to make it the most accessible it can be, whether it's around income supports, whether it's around helping different businesses respond to this crisis. We are making it happen. We're making solutions happen. So I think it's a matter of political will as well. I think here we see a health crisis where it's so adamant that we need to get more people participating and contributing who want to. I think one of the things, just to kind of share internationally, we've seen countries like the UK, we've seen countries like the US and many different states start to figure out how they can simplify their process so we can get people practicing and supporting. So one, I think, is the political will. Two, I think the challenge, and Dr. Nicodeem mentioned this, is the geography, and so did Shamira. I think we have too much complexity across the country, across the different provinces and territories. We need to actually establish a working group or some sort of, we need to see the federal government take a leadership role and say, this is something where this is just an issue that matters too much to our collective interests, that we need to have a proper conversation and a proper, whether it's a task force, a commission, what have you, around our health human resources. I think what we'll find after this pandemic, as we start to enter a recession, we're going to be thinking very crucially about where we want to make investments. We're going to see more investments, I imagine, in healthcare and infrastructure and public health. But I think we need to talk about the workers in those sectors. And I think this is one of the key things I would say the government needs to focus on and take national leadership in partnership with the subnational jurisdictions. So I'll leave it there.
Thank you, Anjum. And I'm going to follow up on the future of it and the situation we're in right now. So Dr. Nikda, maybe I'm going to ask, how helpful would it be for the overall for the healthcare system if internationally trained healthcare professionals are able to support immediately? And your thoughts also on how they can do it beyond this pandemic, just building on what Anjum said, that the future might require that we look at solutions in a little bit of a different way. How can we protect those internationally trained professionals as well?
Oh yeah, great.
Various,
yes, I think it will be really great if we can be able, all internationally educated healthcare professionals can help immediately. But I think it's just on the surface. And my position on this may be not so popular, because I think that this is really a symptomatic treatment for an issue that is rooted deeply in the system. These transitional 30 days restricted license proposed by the regulator during this period is a joke, to say the least. And just because, I mean, it's just one. Someone just mentioned that it's only 12 people have access to that. Let's admit that the number of people who actually qualify, gets into that program. Then what will happen after the 30 days? Yes, you will extend that. Then what? License everyone that has been able to go through that without discussing the health expenditure first? That is just stepping over the bigger problem. And I think that's where really the issue is, where it's not the first time we had a tragedy like this, and it's not like I'm wishing for it, and it's not the last time we will have something like this. But it hurts to see that it's only when things that like these happen, the internationally educated healthcare professionals become part of the solution. And this kind of reduces this part of the capable portion of the population to people who are seem a little bit opportunistic to be proposing the help, and even worse, begging to get their help accepted through the system when these things happen. I think the system knows that they don't have the infrastructures available to accommodate the influx of these many internationally educated healthcare professionals especially doctors, into the system without addressing the budget first, because at the end of the day, at some point, it's a money issue, although there are other problems. And I think this is where the opportunity lies to look at the long-term kind of solution, is to see internationally educated healthcare professionals have a voice that is consistent over time. And it's not like something that pops up every time there is a problem, but to have a more concerted solution to a problem that is really deeply rooted. Because we will have, as long as Canada is a country of immigration and people will come new, we'll have people educated who wants to contribute. And if you're not prepared to help them do just that, you will create a drain of capacity from other part of the world, and that talent is not utilized here. It's just a waste. And we should be in a position where we put ourselves to face these issues with success and really look at ourselves. And I always say that sometimes when we get to the country and someone has even raised this question, is like, is there any straightforward path as to get into these 30 days restricted license? Yes, and on paper, yes, but really practically there is no real path, because everybody knows that the issue is not really the way to get there. It's what do we do with these people afterwards if we don't address that issue. And then what we'll address later on is like, what can we do individually where you are? How can you look at the system, find the right solutions, and get the right bridging programs? Because right now there are so many bridging programs to the point where internationally educated are confused as to where this bridging program are leading, and they don't go anywhere. But to cut it short, it would be great, but it's not that simple. And we have to find then, how do we address long-term, starting with the root cause of this problem? Because there are other people who have the financial means to influence their quota in terms of residency. And we've heard this issue that picked up a few years back, where the Saudi resident pulled back because of some diplomatic issues, and then we knew about it. But you can argue that there is a money issue there on top of other issues that we've heard from other panelists.
Sorry, trying to get to unmuting as always. Thank you so much for that. And I think it answers one of our audience questions on if there's a clear pathway around the COVID-19 talks of you can join the fight. If it didn't, Ahmed, please re-clarify your question if that didn't help. I will want to say, based on what Dr. Nikodem just said, and maybe I'll direct this to both Shamira and Anjum really before I tackle a question we have that's more generic in profession, is one of the questions that many internationally trained healthcare professionals bring to PCAN and the Canadian Arab Institute is, what can I do? Like, what can I do? Like, I understand that there's a situation right now. I understand that there are solutions on the table. Meanwhile, as this unrolls, what role can they actually contribute to being able to help unclog that complex system?
I could start and maybe Anjum you. So, and Dr. Nikodem, you talked about, maybe what you discussed is not popular, but in fact, what I have to tell you is that your analogy is brilliant as a physician, in terms of you have to deal with the root cause before you deal with sort of, just dressing up the wound. So I think that we're basically on the same page in terms of what needs to happen, basically, from, why is this happening to, what are we going to do about it? The reason why I say that, and I'll answer your question in a couple of minutes, Rania, is that for me, if we start dealing with the complexity of the issues and start advocating in such an aggressive manner, unfortunately, the way the system is, and again, I just bring to bear the fact that I was a bureaucrat and no, I'm no longer a bureaucrat, is that you get shut down. There are more powerful people than us, and there are lobbyists, and there is, you know, a lot that happens behind the scenes, which means that you can never move forward. And unfortunately, that's what it is. And then when you put in the issue of funding and who's going to pay and jurisdictions, it just gets more complex. In my mind, the simplest way to deal with it is it's incrementalism. You start with basically, how do you get really practical as soon as you see an opportunity that opens up? So with the pandemic, reason why we approached Okazi and Triac and Costi is we saw an opportunity. They didn't invite us, but we saw an opportunity to say, we're here, guys, and we could do something about it. And that actually opened the conversation and actually has revived the conversation. So with respect to, the systematic approach, and the individual who's asked us the question, what should I do? What we knew is that there were all these portals sitting, the doctors had one, nurses had one, the government put one up, and it's like, how do I start? And so it was a matter of Triac coming, to support us to have one portal. It was just a really simple place to go put your name, and then let's see how we can bring employers. And, people actually did get jobs, not the greatest, but at least it was a start. So for me, in terms of the conversation, you start with the voices. And so how do these voices look? Anjum, you talk about a national place table. I think it's important to do that because the jurisdictional issues are not going to work, and that's what we're doing right now. So we need to have a national table, leadership from our prime minister, and basically invite others, invite provinces, invite voices of people like Dr. Nicodim and others in terms of lived experience. So that's the first step. The second is that I don't see ourselves as being opportunistic when we say we can help you in the long-term care crisis, because there's an opening. I think what they should do is, as they set up that commission in July, they should have voices at the table, because if you look at the people who are getting infected, these might be personal support workers, but their real story is there might be Filipino nurses who came here to work in the caregiving situation and then didn't have a choice, ended up doing PSW work or other places. So let's have them at the table to understand why they even ended up there. So that's basically systematic. But we've got to deal with the root cause, and that's the systemic. And everybody forgot about the fact that the systemic issues are under licensing, and why they're putting all these barriers in place. And we basically need to advocate in a very different way with data and voices and making it difficult, because I think that that's what we lost sight of. There used to be a time, my colleague Joe Natlin, who's doing a lot of this work, is very much about, what do we put on the table in terms of what are the systemic issues and the licensing barriers, and let's talk about it in a realistic way and not just in an abstract, superficial way. And let government hear the voices so that they can make a difference, because licensing bodies are actually the children of governments. Governments give them basically the legislation to put the enter to practice requirements. If they're putting in place enter to practice requirements that are full of barriers, it's up to government and the Ministry of Health and our Premier to do something about those enter to practice requirements. So I think it's a step at a time, systemic and systematic. I hope that helps.
No, I think it's very helpful. And Anjum, I'd like to hear from you as well. I think just one of the things that I'd like to drop in there, because Shamira, what you said is so important. And I know it's very important to the work CAI does, as well as PCAN too, is to make sure that you have a voice, that you have to be approaching this with data, with evidence, and with the with the truly deep lived stories, and many within the community shy away sometimes, especially within those professions, shy away from bringing those stories because they think it's going to be more problematic if I show it, or something of the sort. So Anjum, what do you think is practical for internationally medical professionals today to be able to help with this process?
I think it's absolutely, we need to take a multi-pronged approach. And I agree around how we can leverage our data and evidence. But I would also say, I think the squeaky wheel gets the grease. When we are able to increase the leverage that we have by making this a more pertinent issue, not just for the people experiencing it, but the broader public. So I think rightly Shamira has identified a key policy window here with the challenges our country is facing across the board when it comes to long-term care. We need to leverage this moment. I think now is the moment to actually just increase our voices. I think there's a way to do it that is collaborative and is very much around solutions. But I think we cannot ignore the power of raising our voices in a public fashion, whether it is through media engagement, whether it's through getting the broader public to join on side. I personally think we see shifts in our society when more people know about an issue, but also become allies to the issue. So also encourage, also figuring out ways, people who are not directly affected by the issue, but feel compelled to participate. I think that also increases, just having that coalition of unlikely suspects is what's gonna drive this issue forward, I think. So I think it's getting, when we think about the policy window, it's when we see alignment with the politics, the policy, and the problem. So we're starting to see those different things come together. I'm really curious about the politics side and getting that engagement outside government and creating that outside and inside kind of pressure. So I think if internationally trained medical professionals, if they can engage in civil society, I think that's a really powerful avenue right now.
I really like that. Sorry to jump.
No, it would be great. No, it's great.
But I really like that. I mean, just being able to get involved. But at the same time, I think it's really an empowering standpoint to start from. But also many people will have a question, okay, I still need to feed my family. How am I getting involved in advocating for this while I'm still kind of looking for ways to support my family and make a living? And I will really answer that in a sense of saying that we sometime, and unfortunately, internationally educated professionals forget that they have talents and skills that they have brought with them. It's not up to the system to bring that up, and it's with them. It's unfortunate that we lack sometimes the courage or the I would say the power to put it forward and trust ourselves that we're able to deliver and contribute. And it's not only by practicing. I have to disclose that. For me, I've decided long ago that I'm not going back to practice. And I'm not saying this because I can't. I've worked with many physicians and so forth, and I decided it was not for me, and I wanted to contribute in another way. And each one of us has that other way of leveraging the skills and really put those skills to use, whether it's in health related field or non-health related field, but as long as it's really core to your skills and to something that gives you a purpose, you are able to be doing that and contribute in changing the narrative. Probably you will not get into the system, but if you can make it better for those who are coming after us, that will be a win as well, and it has a sense of fulfillment.
Yeah, totally agree, and I bet this is exactly what passions most of the work you do. The three of you, I can't thank you enough for all your input. I think I can speak to all three of you forever. And this is a topic that I know this is not going to be the last conversation we're having. Thank you so much. I don't think Shireen and the Canadian Arab Institute would have expected it to go so well in terms of, encouraging Canadian Arab professionals, especially internationally trained medical physicians, to start participating, to start voicing themselves, make themselves seen, heard, and work with others to be able to move this conversation forward. I thank you all for your time. Thanks to our audience as well. I know we did have some generic questions about Canadian experience coming as a barrier. And for whoever asked that question, I think it was Ramiz, please feel free to Ramiz, yes, please feel free to connect to the Canadian Arab Institute or PCAN on that matter. The only reason why we're not going to pick it up is because the IMGs, or the internationally trained medical doctors, Canadian experience is not their first barrier at the moment. I thank you all for your time, and thank you to the Canadian Arab Institute and the collective collaborative for bringing this discussion.
Thank you.
Thank you so much.
Thank you for inviting us.
Bye-bye.
Bye-bye.